Thank you very much, Dr. Chairman. Thank you for your kind introduction. It's not easy to come after Dr. Bender and talk about biologic and psoriatic arthritis, but I do my best. I only asked the chairman, you gave him so much extra time. I need few more extra time because 20 minutes is very short. So, okay, let me do here. These are my disclosure. So I was given a very simple task, basically talk about the psoriatic arthritis and how we're managing psoriatic arthritis in our rheumatology clinic. So although I'm a rheumatologist, but I'm starting with a slide showing all the comorbidity. I think one of the messages that we're trying to convey to dermatology that we should be looking at this disease as a systemic inflammatory condition. It's not anymore about the skin and the joint. It's actually these patients have many other problems. The risk of having diabetes, cardiovascular events. They also have all the list we see with patients with hyperuricemia, gout. So you really need to look over all the treatment. And when you're deciding to start whatever treatment you're going to start this patient in terms of a biologic or other biologic, also consider other comorbidity. I'll show you some of the data to make you convinced why this is important. So Dr. Bender, as a rheumatologist, we're also a good internist, so we look up after other diseases, and I'm going to show you that we do screen some of diseases. So this is just a two piece of information from the data from the literature looking into a cohort of more than 9,000. On the left-hand side, you're seeing the hazard ratio of actually mortality in patients with psoriasis. And if you're looking in the Y bar graph, you're seeing the hazard ratio is around 2. So your risk of dying just from having a skin psoriasis is double than general population. And there's, even if you adjust it for age and sex for the general population. In the right-hand side, you're seeing a different graph for diabetes. Again, the higher the percentage of PSA you're having with skin psoriasis, it is actually more risk of having diabetes. And you see below that graph, for each 10% increase in the PSA alone, you have an increased risk of around 20% of having diabetes. So part of the things that we do is in our psoriatic arthritis clinic, we also screen for these conditions. We look for the uric acid, we look for hemoglobin A1C, we ask questions about family history, and if we need it, we refer them to an appropriate physician to treat these conditions. So this is very important. Look at the disease as a systemic disease, not just looking into the skin, it actually can affect other organs. This is a different looking to comparison into the cardiovascular. You live in a country which unfortunately obesity is very prevalent, and also cardiovascular disease is also very prevalent. And if you're having psoriasis or other inflammatory condition, that it actually increases your risk. For us as rheumatologists, we always tell our patient with rheumatoid arthritis, for example, if you have rheumatoid arthritis, your risk of having cardiovascular events is much higher than general population, around 4 times. And this is just one of the studies to compare the 3 common diseases that we see in this country. The green bar here represents psoriasis, the yellow bar represents rheumatoid arthritis, and the red bar represents psoriatic arthritis. So if you look to cardiovascular death, for example, in the middle, you're seeing the top 2 goes for psoriasis and rheumatoid arthritis. So you just having a skin psoriasis actually puts you at risk of having cardiovascular event. Again, it's important that we should be screening these questions. I know we're all busy in the clinic, and sometimes you have only 10 minutes or 15 minutes with our patient, but I think we should be focusing on these comorbidity and trying to address these comorbidity. So what do we do as a patient with the psoriatic diseases at the dermatological perspective? We basically get a good details. We as a rheumatologist take an exact history. Do you have any joint pain? I know some of you has used PEST screening question, asking 5 simple questions and filling the allogram of having any joint pain. If you had endothelial pain, if you're having worsening of the skin condition, have you been starting any new treatment? Have you been diagnosed with any new diseases? Basically taking a full history that's going to be useful in making these diagnoses. We also encourage our rheumatologists to talk about the psoriasis and sensitive area, like the genital area or an various nail, and we also look for nail changes. 80 to 90% of patients with psoriatic arthritis have nail changes. And this is one of the things, the outcome we're looking for when you're putting these patients on biologic agent. You tell them also your nail that you've been told probably by different physicians, it's a fungal infection or other diseases. This is related psoriatic arthritis and psoriasis are going to improve with the biologic agent. What about treating to target? Treating to target is a concept that we developed in rheumatology around 15 years. It started with rheumatoid arthritis. We're aiming to treating patients to have a clinical remissions. We have applied this also for psoriatic arthritis. So one of the common trial that we're using called the TICOBA. So TICOBA is basically looking for 200 patients who had psoriatic arthritis and been followed for 2 years, and they were DMARD naive. And we have two randomized, two arms. So one of the arms is a tight control. So these patients we're seeing more frequent in the clinic, and their drugs has been adjusted more frequently in comparison to the standard care. Standard care usually involves a follow-up every 3 to 4 months. And you can see on the left-hand side that this is our outcomes as rheumatologists. We used an ACR 20, 50, and 70. And as simple as this is basically a 20% improvement in joint pain, joint tenderness, inflammatory markers of improvement, and the morning stiffness, and we do as a composite index. So you can compare the tight control group with the standard of care, and you see a dramatic difference. There's a 62 ACR 20 response in comparison to 44%. If you look into the skin, as a rheumatologist, you see a PASI 75. Also, you see almost a double number in PASI 75 in tight control, around 60% versus the 30%. And that makes sense because you're seeing the patient is more frequently. Now, this is obviously a challenging in the private sector or even the government sector when it's so busy and you can't really see that patient that often. But this is just a proof of concept that if you do a tight control, you're seeing the patient more frequently, and adjust the medication for frequently, you're getting a better outcome. Obviously, that will be obvious on the use of the treatment. So if the tight control you're seeing, for example, using biologic around 40% in comparison to standard care, and using a combination of DMARD is almost triple the number of being using the standard of care. And that's how you'll be able to achieve these numbers. So when we talk about psoriatic arthritis, I think Dr. Bender already showed you some slides about the pathogenesis. There is multiple cytokines that have been involved. We have drugs target interleukin 17. We have drugs that target interleukin 23. The old anti-TNF they've been using over the last 20 years, and now more recently we have the JAK inhibitor that have been approved for treating of psoriatic arthritis. This is probably a very familiar graph for all of you. I use this also to explain it to my patient when I make a diagnosis of psoriatic arthritis. I'm telling them I'm going to give you a drug that is not going to address your joint. It's going to address your joint, it's going to address your back pain, it's going to address your enthesitis problem, dactylitis problem, and also nail changes. And when you put it in this way, I think you have a better success of convincing patients to be on these agents, especially when you're talking about using an injection, depending on the mode you're using. So axial disease, typically these patients come with inflammatory back pain. In Kuwait, around 10 to 15 of patients with psoriatic arthritis may have an axial disease, but it's a little bit different in comparison to ankylosing spondylitis. Neck pain is quite common in patients with psoriatic arthritis, so don't ignore every neck pain in psoriasis patient because this actually can be a spondylitis. Could be a disc disease, could be a muscle spasm, but it also can be a spondylitis. So if you have a patient who have a persistent neck pain, please don't ignore this. Maybe you want to refer them to a rheumatologist or do an MRI because it can be actually a spondylitis. Pain in young people that wake them up in the morning, they wake up with pain or they have stiffness in the morning, and the pain improve with movement and actually worse when they get rest. That's an indication that could be an axial disease, and you can do a SI joint MRI to look for bone edema and maybe erosion. Enthesitis is quite common in general population, but enthesitis and psoriatic arthritis is a little bit different. You see a little bit swelling around the enthesial part. Here in the picture, I'm showing you Achilles tendinitis, where you can have a tennis elbow, you can have a pes anserine, you can have any other bursitis with enthesitis, the golfer elbow. These are common sites that's involved with psoriatic arthritis. Dactylitis is relatively easy to diagnose. Skin disease, you're probably an expert diagnosing skin disease, and nail disease said 80 to 90% of patients with psoriatic arthritis will also have nail changes. So these are how common are these manifestations. So if you're looking for peripheral arthritis, so peripheral arthritis could be an oligoarthritis. So you can have 2 or 3 joints. It could be an ankle, it could be a knee, it could be a wrist. If you have less than a 3 or 4, you have an oligoarthritis. But it could be actually like rheumatoid arthritis, like a polyarthritis. You see a 40% chance of having a polyarthritis and around 80% or 60% around having oligoarthritis. Spondyloarthritis, the number here in the graph is around 46. This is more a North American, European studies. Actually in Kuwait, I think it's less common. We don't have an official study, but I would say 15 to 20% of psoriatic arthritis in Kuwait probably have axial involvement. Dactylitis also, you see it in around 40%. Enthesitis is quite common. I would say half of the population we're seeing in the clinic will have some form of enthesitis, and I would say Achilles tendonitis is by far is the most common. I wouldn't talk about the skin disease. We already talked about the nail changes and the other comorbidities. So the patient can present with uveitis. They can have uveitis at the beginning of disease. They can have a history of uveitis, and that may have alter your choices of treatment. And also you have to be cautious about bowel symptoms and the chance of having inflammatory bowel disease. So when we talked about treat to target, so we had a long debate about which target to use. And in rheumatoid arthritis is more concrete. It's still a big debate in spondyloarthritis and which our targets. And you will hear different speakers talk about different target. I found this is a very simple one that we can apply in our clinic called the minimum disease activity. And basically to have a minimum disease activity score, you need to score 5 out of 7. I want to have less than 1 tender joint, less than 1 swollen joint. I have a PASI of less than 1 or a PSA of less than 3%. Patient global VAS on a scale of 100, you want to be less than 15. Patient global assessment also less than 20. You have a health assessment, which is the health questionnaire. We ask about the functionality of the patient to be less than 0.5, and you have less than 1 enthesial part. So I find it more easier to apply minimum disease. The only thing that doesn't address this is actual axial disease. We use a PASI score in more research setting where we're looking for the axial symptoms, but this is very good for your peripheral arthritis. So this is a piece of information for one of the studies where a substantial proportion of patients diagnosed with psoriasis only report joint-related disease. This was a simple questionnaire just sent to the patients. It's not confirmed by physicians. And they ask them whether you have joint pain, whether you have stiffness in the bonding, whether you have swelling. They ask specifically about enthesial part. And you see out of around 3,500 patients, they were surveyed. Around 80% of the population said we have some diagnosis of psoriasis in the past alone, but also they report around 50% of the patients in those psoriasis may have some sort of joint pain. Around also 16% of patients have enthesial-like symptoms in psoriasis patients, and also around 1/3 of the population were reporting some history of dactylitis. It may not be truly psoriatic arthritis because it was basically a patient survey, but I'm just trying to point that this is quite common that you see it in psoriasis clinic. I'm not going to discuss this in detail because you're probably more expert than me. This is what you have been using in the past to treat psoriasis, right? Whether it's a different topical treatment, the different DMAR, conventional DMAR, the ultraviolet therapy, where we talked about the biologic agents. We're lucky in Kuwait, we have many biologic agents to treat psoriatic arthritis, including the 5 anti-TNF. We have the interleukin-12/3 Stelara. We have the 2 interleukin-17, Cosentyx and Taltz. And we also have the 2 interleukin-23. And the most recent addition to our arsenal is also the JAK inhibitor. This is just a graph showing you the drugs that have been approved over time, over the last 20 years for psoriatic arthritis. And you can see over the last 5 years, there's a lot of addition to our arsenal. I think we still have unmet needs. If you're looking at the literature in psoriatic arthritis, it's around only 30 to 40% of patients achieve actually minimum disease activities targets. So there's a lot of patients that still require other treatment or a combination of treatment. And I think just having these options is actually a blessing for our patients. So I'm just going to go over some of these drugs that I've been using. Methotrexate we've been using methotrexate for a long time, for more than 25 years. So this is one of the studies for using methotrexate in early psoriatic arthritis. It's called the SEAM, psoriatic arthritis treatment. There was comparison between etanercept and methotrexate in combination as a monotherapy and were randomized into one-to-one fashion. The median psoriatic duration was around 0.6, so these were really early patients. Methotrexate arm has been maintained in a median dose of 20 milligrams, so it's a good amount of methotrexate has been used in this trial, and also more reports of nausea in methotrexate patients. So if you're looking into the graph here, I showed you about the ACR20. So the ACR20 is basically the 20% response in patients, and you're seeing the combinations here represented by the dark green color. This is the combination of etanercept plus methotrexate. But if you look into the blue colors, actually methotrexate. So around 50% of people had responded to methotrexate alone with a dose of 20 milligram. Obviously, if you combine methotrexate with etanercept, you're having a higher chance, and the percentage goes above 60%. But in some patients, methotrexate alone can work in patients with psoriatic arthritis. What about other agents? So this is not to head comparison with a different drug that we're using for psoriatic arthritis. So starting from the left-hand side, you see the methotrexate response. This is just looking into the PASI 90. You're all familiar with the PASI 90, 90% response. So you can achieve PASI 90 with methotrexate alone, but your chance of achieving that is only 9%. If you move to apremilast, it's similar to methotrexate. Then you move to the anti-TNF, you're seeing the number is actually getting higher. There's around 40 to 50% chance of achieving PASI 90. And then you're going to the Stelara here, you're seeing around 45%. Moving to the 2 or the 3 interleukin 17 inhibitor, you see the percentage actually going higher, above 60% and 70%. And on the right side, you're seeing the interleukin 23, and you see the percentage around 70 to 75%. These are numbers for PASI 90. And these are the numbers for the ACR20. Again, these are not to head comparison. I'm just putting these numbers to show you how effective these drugs. So I'm just giving you an example on the top here, at the top three. The first one is the using adalimumab versus placebo is around 60% chance of achieving ACR20 at week 24. Next one, you're seeing Future 1 and Future 2, where we use secukinumab versus placebo. As a rheumatologist, we start with 150 milligram secukinumab with a loading dose and every 4 weeks, and you're seeing the number there. And then moving on the other side is the Stelara for the Summit 1, the P-Summit 1 and P-Summit 2, and you see the number of ACR20. In the bottom, you see the Palace 1, Palace 2 for apremilast. The chance of achieving ACR20 in 16 weeks is around 40%. And then you're moving to one of the interleukin 17, TAL, so you're seeing the percentage that goes to around 55%. And on the right side is tofacitinib, the JAK inhibitor. It's also approved for psoriatic arthritis. And you see there's a 50% chance of achieving ACR20 in comparison to placebo. What about head-to-head? I think you guys are very lucky in dermatology because you have so many head-to-head studies. It's not the same, similar to rheumatology. We always tell the pharma that we want head-to-head because we have so many options right now, and there's always challenges which the patient is deciding which patient is going to respond to which medication. But I'm just going to use some of the one or two few examples that we're having with the head-to-head comparison. So this is the EXCEED trial. This is head-to-head comparison of defining interleukin 17 inhibitor superior to anti-TNF. So basically it's a phase 3 randomized controlled trial comparing secukinumab versus adalimumab. The secukinumab dose has been used as a 300 milligram. They have received the loading dose and then receive it every 4 weeks in comparison to adalimumab and a standard dose of 40 milligram every 2 weeks. The primary endpoint were the ACR20 response at week 16. I'll show you, let's go back. So I'll show you the response rates actually on the right side. So for secukinumab, the ACR20 were achieving around 67% of the population versus 62% with adalimumab. In that trial, they also were presented at a combined endpoint where you have the ACR50, so the 50% response from joint perspective, plus the PASI 100. Here you see a dramatic difference between secukinumab because it was achieved in 31% of the population in comparison to 19% to adalimumab alone. So obviously the interleukin 17 secukinumab here specifically work better in terms of the skin. It works similarly for the joint, but they were better for the skin. Okay, so this is a graph, you probably have seen this. This is from EULAR. This is our European association where these write recommendation for using different biologic agent in psoriatic arthritis patients. So the proposal for EULAR to use these biologic treatments after conventional DMARD. Obviously, there's exception to these rules. You have a bad skin disease, bad psoriatic arthritis. I mean, when they write these guidelines, they also consider cost, consider access to treatment, the availability. We are privileged here in Kuwait. We actually can use these agents as if you think the patient is going to benefit from these treatments. So in the green light here, you see where they did their recommendation based on a statistically superior comparing to placebo. And so you see, for example, TNF, interleukin-17, the Stelara has been approved in terms of arthritis, improving physical function, skin disease, enthesitis, dactylitis, and also some of these studies showing radiological improvement, mainly preventing erosion, preventing damage in the joint. For JAK, for example, when this came, there's only TOFA was approved at that time. Obviously, we had other agents had been approved since then, and you see there was no enthesitis data or dactylitis. There was more data showing after this publication. So another piece of information I want to show you is which Dr. Vender has been talking about. It's not just important that my patient is going, I want to put the first agent I'm going to use, I want to have a higher success, but I also want to make sure this success is going to last for a long time. I don't have to come after 2 or 3 years I have to go and change the medication. I'm going to hit it hard, as he said it. I'm going to start strong and last long. Then I'm going to probably taper the dose rather than just stopping or switching to another medication. So this is a study we're looking into the survival rate for the first-line biologic DMARD in psoriatic arthritis. So we're looking at different number in year 1, year 3, and year 5. So you're looking into the graph directly. The top line here, the green light is for the interleukin-12/23 inhibitor. The orange color is looking for the interleukin-17 inhibitor, and the light blue for TNF. You're seeing, obviously, with time, you're losing some of the efficacy. And this is this is a more psoriatic arthritis patients, and the mean biologic DMARD persistence were around 17 months. Now, some of us will say this is actually very short, because in other diseases like for us in rheumatoid arthritis, actually the anti-TNF, for example, can last for 2 years. So this is, for us, is not surprising. Maybe from the dermatology perspective, is a little bit different. I'll be curious to hear Dr. Vender's opinion about this when we go in the Q&A section. So for interleukin-17 inhibitor and interleukin-12/23 rates are marginally better than TNF, but still are modest overall. Now, there is other studies probably showing the better survival drug in terms of the 17 or 23, but I'm just giving you one of the pieces of information that have been published in JAMA Dermatology and also in arthritis research. GRABA updated treatment, you probably have seen this. We love this because this is divided into domains and tell us which drug to use in different domains. In the left-hand side, we started with peripheral arthritis, and the blue one is axial, enthesitis, dactylitis, psoriasis. It's a common theme you're seeing there that conventional DMARD work for peripheral arthritis. We can use methotrexate, leflunomide for peripheral arthritis. It doesn't work for axial disease. You go directly to biologic agent after using NSAID. You still can use conventional DMARD for enthesitis, dactylitis. For the skin, you know better than me in terms of the skin, and also for nerve disease, we look for biologic agent, not a conventional DMARD. You see TNF in all of these domains. You see interleukin-17, except you don't want to use it in patients who have active inflammatory bowel disease, and then also on uveitis. So I like this GRABA recommendation because it goes with the domain. It's more clinical relevant and tell you what kind of a drug. If your also first-line agent had failed, this also tell you where you can switch to other agent also at the same time. So this is the slide where it tells you about, again, when I want to make a decision about which treatment I'm going to use, I'm also going to talk about if it's just psoriasis, is it psoriatic arthritis, is it psoriatic arthritis in a patient who have congestive heart failure, if this patient have other comorbidity, maybe a patient have history of multiple sclerosis. So this This is a very busy slide, but it's also tell you about which agent you can use in the right population. I mean, we just don't look for the skin. We're looking for the overall patient. We look for the skin, joint, axial disease, comorbidity, if they have other associated diseases like uveitis or inflammatory bowel disease. So I'm going to just finish. This is my last slide about the importance of having a combined dermatology clinic for management of patients with psoriatic arthritis. I was very happy that for 1 year hospital, around I think 2 to 3 weeks, announced they have their first combined clinic by Dr. Abir and Dr. Khulud. This is very good for patients. I think this should be an example where care of the patient is going to be improving. You have 2 consultants sitting in a clinic where one look for the skin, one look for the joint, and they're also discussing what these patients. I personally, when I was doing this in Canada, I was learning from dermatologists all the time. I'm learning all about all the creams, all the tricks they're using with their patients. I think it's good to improve knowledge and patient care. If you look to the benefits, it's improved patient care, abuse communication between healthcare. You don't have to send the patient, go and ask permission of your domestic. They're both sitting in the same room. I think that's going to be eventually improving patient care.